Welcome to our Thrombosis Canada Virtual Conference. I am Lena Castellucci, and it's my pleasure to be co-chair of the first virtual conference for Thrombosis Canada. I am a general internist and thrombosis physician from the University of Ottawa at the Ottawa Hospital. And it's a great session that we have planned for you tonight. We're talking about direct oral anticoagulants in special populations. Before we begin with our presentations, I just want to remind you all that the system will automatically mute all participants except for the speaker. And if you have questions, please use the question and answer box at the bottom of your screen, and we will address these at the end of the presentation. I would encourage you to enter in your questions throughout the presentation rather than at the end of the presentation. And as a reminder, our sessions are all recorded and will be archived on the Thrombosis Canada website. During the conference time, they will also be available on the conference platform. So next, we're going to move into our first session, and it's my pleasure to introduce Dr. Allen Tran. Dr. Tran is an assistant professor in the Division of General Internal Medicine at Dalhousie University, and he is the current program director for General Internal Medicine residents. He completed medical school at the University of Alberta and completed residency with core medicine and general medicine at Dalhousie. During his GIM residency is where he developed his interest in thrombosis, and he now practices thrombosis medicine as well as GIM. And his presentation tonight is direct oral anticoagulants in patients with renal dysfunction and liver disease.
Great. Thanks so much. Thanks for having me. So I'll just go through the initial disclosures. I've been involved in studies by Jen Fitshire, Allergan, Intercept, and Novo Nordisk. In terms of commercial support, so this conference has received financial support from Alexion, Bayer, Leo Pharma, BMS, Pfizer Alliance, Pfizer Hospitals, Sanofi, and Servier in the form of a conference grant. And the agenda and faculty for this program was developed by the Planning Committee for Thrombosis Canada. All faculty have been directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the CME CPD activity in support or justification of patient care recommendations conforms to generally accepted standards. All right, so I'm hoping that by the end of this session, you'll be able to develop a risk-based approach to prescribing DOACs in patients with renal dysfunction and/or liver disease, as well as recognize the limited data when it comes to using DOACs in this high-risk special population. So the approval of the DOACs has led to an increase in the number of patients on anticoagulants over time. Unfortunately, there's probably too much early adoption, as it was being used in patients outside of the studied RCT population. For example, a US database study from 2010 to 2014 found that about 3% of dialysis patients were being prescribed Apixaban or Recanalization, despite the complete lack of evidence in this population. And that was soon after FDA approval. In addition, a Korean study noted a high prevalence of DOAC use among patients with liver disease who were all excluded from the landmark RCT trials. And since the RCTs were published, the renal function thresholds for these medications are now lower than what was studied in those RCTs, where our most robust data comes from. So this can be problematic because we want to make sure that we do no harm, first of all, and that we want to make sure that the medications we're using are effective in these higher risk populations of renal and liver dysfunction, as well as we want to make sure that any new treatment is comparable to the current standard. So let's look into the data then of the special population of renal dysfunction and liver disease, and we'll start with renal dysfunction. So I think some important things to consider is that anticoagulants are used predominantly to treat two different conditions, atrial fibrillation and venous thromboembolism, and that these have different thrombotic risks associated with them. And the associated patient risk factors or comorbidities can be quite different as well. In the special population of renal dysfunction, we have to keep in mind that there are dialysis patients, as well as patients with severe chronic kidney disease that are not on dialysis yet. And the impact of the drugs may be different on these two different subpopulations. As well, patients with CKD have both higher thrombotic and bleeding risks in general. And those on dialysis also receive a decent amount of heparin during their hemodialysis runs as an extra complicating factor. So as a reminder, the pharmacokinetic data of the main DOAC, so Apixaban is the least renally eliminated, whereas Apixaban is the most renally eliminated. And so the approval of DOACs at creatinine clearance thresholds lower than in the RCTs has come from pharmacokinetic studies. And these studies did have very few patients overall. For example, the Apixaban study that led to the FDA approval in dialysis patients was a single dose study of 16 hemodialysis patients. And all these pharmacokinetic studies were not focused on clinical outcomes at all. And in terms of looking at over this data, some of the themes I found is that in the dialysis population, it seems that a half-dose DOAC seems to provide similar drug levels in dialysis patients as it would be as a full-dose DOAC in a patient with normal renal function would have. And all this varying data has led to the regulatory authorities across the world having different approvals overall in terms of the DOACs. So this is the data from product labeling in Canada, and essentially, as long as your creatinine clearance is above 30, everyone's pretty happy for you to use any of the DOACs that are approved. Keep in mind the dose reductions for rivaroxaban and Apixaban for AFib, as well as Apixaban for both AFib and VTE. And then in Canada, rivaroxaban and Apixaban are approved down to a creatinine clearance of 15 based on the product labeling. Interestingly, the Apixaban product labeling actually does not give a suggested dose for AFib at this range. The FDA does approve Dabigatran as well as Apixaban in this range as well, and the European Medical Agency approves Apixaban down to this threshold of renal function. And in terms of renal function less, with a creatinine clearance less than 15, or on dialysis, Apixaban is the only DOAC approved, and that's by the FDA only. So let's look at the clinical data we have for use of DOACs in patients with severe chronic kidney disease and atrial fibrillation. So this is a meta-analysis of the landmark DOAC studies for atrial fibrillation. And we see that in this group of patients with the creatinine clearance above 80, the DOACs seem to have an association of less major bleeding compared to warfarin, and no significant difference in terms of stroke and systemic embolism, but a trend towards a benefit in terms of DOACs. And then when we look at renal function below this threshold of 30 to 50 or 50 to 80, the major bleeding association of benefit is preserved. It seems that patients on DOACs had less stroke and systemic embolism as well compared to warfarin. And remember that these are the landmark trials, so they all excluded patients with a creatinine clearance of less than 30, or in the case of Apixaban, less than 25. So while promising for those patients with worsening renal function, again, there may have been too much enthusiasm initially. So as I alluded to earlier, this graph shows that patients the patients on hemodialysis who are prescribed Dabigatran or rivaroxaban, and then these empty circles are when FDA approval occurred for these medications. So you can see that shortly thereafter, within half a year or so, patients on dialysis were being prescribed these DOACs, despite no real studies in this specific population of patients near this degree of renal dysfunction. And unfortunately, this was associated with harm. So the study was retrospective, but it found an association with increased major bleeding with DOACs compared to warfarin. And in addition, there's an increased risk of hemorrhagic death with Dabigatran, but not necessarily with rivaroxaban, though you see the lower limit of the confidence interval is quite close to 1. The frequency of thrombotic events were quite low, so they're unable to do any adjusted analyses for this outcome, but there's no significant difference in terms of unadjusted analyses between rivaroxaban and Dabigatran compared to warfarin in hemodialysis patients in this study. And so once Apixaban was approved for patients on dialysis in the US, data started accumulating. This led to this large retrospective study that looked at patients on dialysis who were either given Apixaban or warfarin for atrial fibrillation. So this was a sicker population overall with a mean CHADS VAS score of 5, and about 10% of them had already had major bleeding in the past. A recurring theme is that with all these, so many of the studies in this subpopulation, that many of them did not end up actually staying on the anticoagulant for that long. So in this study, around 60% of the Apixaban users were presumed to have stopped their Apixaban by about 100 days based on prescription records, and about 70% of warfarin users were presumed to have stopped their warfarin by 150 days. And so what the authors found was that there was no difference in terms of thrombotic events, but there was an association of less major bleeding with those who were on Apixaban. This did not translate necessarily to a lower risk of death, but you see some separation of the curves up to about 400 days or so. I think another striking finding from the study is the actual event rates. So here for stroke and systemic embolism, we see very high rates overall in this study. So this is about 12 per 100 patient years. And these are patients who are on anticoagulants. So recall that the mean CHADS VAS score in this study was 5, which would translate to about 7% stroke rate per year off of anticoagulation. Major bleeding rates were extremely high, so around 20% or so, or just a bit above that, as were GI bleeding rates. Even intracranial hemorrhage rates were relatively high, so 3 to 3.5%. Whereas in the landmark trials of the very selected population, the ICH rates are around 0.5%. And then the death is quite high, reflective of this sick population. When looking at the dosing and seeing if that had any association in terms of these outcomes, we see that both doses of Apixaban were associated with less major bleeding compared to warfarin, and that the 5 milligram dose was associated with less stroke and systemic embolism, as well as less death compared to warfarin. Again, this was a retrospective study, so there's selection bias and residual confounders that could have contributed to these findings. And then once Apixaban was approved for dialysis patients, some RCTs began to recruit patients for studies. So this is data from the Renal AF study, and they presented their interim data at the AHA last year on their first 154 patients. So this was an RCT of Apixaban versus warfarin in patients who were on hemodialysis and were being anticoagulated for atrial fibrillation. And their main outcome was clinically relevant non-major bleeding, and they actually found no difference thus far with this interim analysis. And again, the rates were quite high, so 25 to 30% of patients seem to have clinically relevant non-major bleeding. The rest of these outcomes, the numbers are quite low to make any kind of analyses. And unfortunately, I heard that the study lost funding, so we may not get the full picture ever, at least from the study. Looking at other DOACs, here's a propensity match study with rivaroxaban and warfarin in patients with stage 5 CKD. So it was unclear from the study how many patients were actually on dialysis. But you see that there didn't seem to be any significant difference really in terms of any of the outcomes, except for a major bleeding that just reached significance. I think the other important finding from the study is that these event rates are quite low compared to that last Apixaban study I presented. So stroke and systemic embolism rates of around 1 to 2 per 100 person year versus 12 in that Apixaban study. And major bleeding rates also on the lower side. So this could just mean that this population was not as sick. And the mean CHADS VAS score here was 4, and the mean time on the oral anticoagulant was around 112 days. There's another propensity match study looking at Apixaban and rivaroxaban patients who had end-stage renal disease. And again, there didn't seem to be any clear difference or signal difference between the two of them. The event rates here are low as well. When you look at the subpopulation of severe CKD, that is a creatinine clearance of less than 30, but not in dialysis, there isn't as much data here. I found the single center retrospective study, which had a large proportion of non-dialysis patients and a mix of patients with CKD stage 4, so a creatinine clearance of 15 to 30, or stage 5 disease. And these patients were anticoagulated mostly for atrial fibrillation, though there are some who are anticoagulated for VTE. And they're looking at Apixaban compared to warfarin in this retrospective study. They found thrombotic risks were similar, around 1% in each group, and that any bleeding, or any clinically relevant bleeding was around 8 to 10% at 3 months. When they looked at it over the next year or so, next 12 months, the warfarin users had a persistently elevated bleeding risk, whereas those on Apixaban did seem to have their bleeding risk drop off. Though again, they didn't really provide data on how many patients in each group were stopping their anticoagulant. So before I can talk about an approach to which anticoagulants to consider in dialysis patients, I think you really have to answer this question first. Is anticoagulation beneficial at all for atrial fibrillation in patients who are on dialysis? I don't want to get too much into it because this is its own talk. But this is a retrospective study from this year that suggests that warfarin in dialysis patients for atrial fibrillation may not be all that helpful. So there's no reductions or association of reductions in death or stroke, and there were associations of increases in terms of all-cause hospitalization, bleeding-related hospitalizations, and intracranial hemorrhage. And in a high heterogeneity network meta-analysis of patients with atrial fibrillation on dialysis, again, we find similar findings here where warfarin does not seem to have any associated reduction in terms of stroke compared to no anticoagulant, and Apixaban had similar findings as well compared to no anticoagulant. And then in terms of major bleeding, warfarin, dabigatran, and rivaroxaban were associated with more major bleeding compared to being on no anticoagulant, whereas the Apixaban doses were not. And this was another study that was a propensity score matched study looking at Apixaban versus nothing or no oral anticoagulant in dialysis patients with atrial fibrillation. And here they found that Apixaban was not associated with any reduction in the primary outcome of stroke, TIA, or stroke or systemic embolism, and that Apixaban was associated with more fatal or intracranial bleeding, so around 5 versus 1.5 events per 100 patient years in terms of major bleeding. When they looked at the subgroups of the doses, so the 5 milligram dose was still associated with higher rates of bleeding without any reduction in stroke, and that the 2.5 milligram dose was not associated with this higher risk of bleeding or stroke, so it's somewhat equivalent to being on nothing. And then finally, looking at the VTE data appears to be even more sparse in this population. So the studies are quite small overall in terms of DOAC users, and I generally found Apixaban studies. And most of them were mixed studies of both VTE and atrial fibrillation. Overall, it's somewhat similar to the AFib data that I presented. There's no real clear signal of harm compared to warfarin in terms of bleeding or thrombotic outcomes. But one of the main points to make with VTE is that the dose reductions for the anticoagulants have not been studied for acute VTE treatment. And in this one study, which was predominantly of patients with creatinine clearance was actually above 30, patients who were treated for acute VTE with a dose-reduced DOAC had a higher hazard ratio of VTE recurrence. They also had a higher hazard ratio of major bleeding. That just may reflect the selection bias as well. So I think in terms of this part, some of the key points that I hope I highlighted was that the data in this high-risk subgroup is predominantly retrospective, mostly for atrial fibrillation, mostly for Apixaban, and in patients who are on hemodialysis. For atrial fibrillation, the thrombotic rates seem to be similar between warfarin and Apixaban or rivaroxaban, though again with limited study quality. And the bleeding rates don't necessarily seem to be higher with DOACs compared to warfarin. Of course, there's a lot of limitations with all of this data, as well as the amount of time you actually spend on the anticoagulant in general. And if we're going to look at VTE, we're using even more extrapolations due to less data. So in terms of an approach, so I think anytime you're thinking about anticoagulating any patient, I always think about trying to mitigate bleeding risk factors as much as possible, stopping unnecessary antiplatelets, controlling hypertension, falls risk assessment, et cetera. First question should always be, is anticoagulation needed? And putting into the context of the patient, especially frailty, as a general internist. And so if anticoagulation is not needed, then don't give it, which is good. If it is needed, then I ask myself, is this patient with AFib, is there a strong reason to use warfarin? So do they have valvular AFib, or is there a mechanical valve? And if yes, you're somewhat stuck with warfarin. And I ask, is there any strong reason not to use warfarin? So in this special population of CKD patients, you wonder, is there any history of calciphylaxis? And if there is, you probably should not be reusing warfarin. And again, having an informed discussion with the patient, as well as considering Apixaban or rivaroxaban after discussing this with the patient. If there's none of that, and then I ask, is the creatinine clearance still above 15? If it is, then Apixaban and rivaroxaban are approved in Canada at this threshold, and the data would not suggest that there's a clear higher risk with using this. And warfarin, of course, is always an option at this time. If the creatinine clearance is less than that, again, obviously informed discussion, warfarin for the patient. I'm not quite an early adopter of this yet, but I think you can consider Apixaban if you're really having a hard time with keeping warfarin in the therapeutic range. And then whether you should try the 2.5 milligram BID dose first to ensure that the patient can tolerate it at all, and then potentially increasing the dose if it is for a strong reason that they need to be anticoagulated for AFib. And then similarly for VTE, again, the same mitigating bleeding risk factors and asking myself if anticoagulation is needed. And then if it is, I ask myself, is there a strong reason to use warfarin, such as is there high-risk antiphospholipid antibody syndrome? If yes, then use warfarin. If not, the calciphylaxis question. And then I also ask myself, is this after the 6 months, the first 6 months of full dose anticoagulation? Whereas you could consider extrapolating data from the extended VTE treatment trials using dose-reduced Apixaban or rivaroxaban. Again, these are extrapolations, but I don't think it's unreasonable to use the dose-reduced versions at that time. And then, of course, if that's still within the first 6 months, asking myself, is the creatinine clearance above 15? If it is, then again, there's no real dose reduction studies for using DOACs for acute treatment of VTE. So warfarin is probably the main one that you could consider Apixaban or rivaroxaban after some informed discussion with the patient. And then if your creatinine clearance is less than that, most of the data is with warfarin. And a similar aspect, like the last slide, about considering Apixaban if we're really having a lot of trouble with warfarin. Okay, so that whirlwind is over. And then looking at this other high-risk population of liver dysfunction. So similarly, again, two different conditions that we're treating with blood thinners, AFib and VTE, and the associated different patient profiles as well as thrombotic risks. In the literature, liver dysfunction is variably defined. So this could mean just elevated liver enzymes, it could mean fibrosis, or it may mean cirrhosis. And then cirrhosis can be graded in terms of severity as well. When looking through these studies, there are many varied dosing regimens. So there's full dosing, there's reduced dosing, then there's reduced dosing, but not necessarily for the usual reasons, as well as completely new dosing, which I'll talk about as well. And in this population, again, they have higher thrombotic and bleeding risks. And we also have to potentially worry about variceal bleeds in this sick population. So this is the product labeling for Canada. And in the RCTs, they generally excluded patients who had ALTs of above 2 to 3 times the upper limit of normal or significant liver disease. And from the product labeling, most of them suggest caution when using it in patients who have child 2A cirrhosis. Rivaroxaban is a bit more conservative with child 2B and suggests not using rivaroxaban in this population, whereas the other ones again suggest caution. And none of them, and all of them say that their DOAC is contraindicated in child 2C cirrhosis. In terms of the pharmacokinetics, there may be some differences based on the stage of cirrhosis as well. So from this study, they found that the AUC was different with rivaroxaban. It was higher in patients with child 2B compared to child 2A, whereas this wasn't seen with the other DOACs. Another interesting study was this one where they gave control patients and patients with various degrees of cirrhosis a DOAC and then checked their endogenous thrombin potential, which can give some sense of coagulability. And in it, for dabigatran, they found that dabigatran had more of an anticoagulant effect as the cirrhosis advanced, whereas for rivaroxaban and as well as Apixaban, there seemed to be a similar anticoagulant effect in controls, child 2A and child 2B. But once patients had child 2C, those ones seem to have less of an anticoagulant effect with rivaroxaban or Apixaban. None of these studies had any clinical outcomes though, so it's hard to know exactly what to make of this. So then asking that initial question is there any benefit to anticoagulating patients with cirrhosis who have atrial fibrillation? So I think this study did a great job of trying to answer it. There was another retrospective study. They used propensity score matching to simulate an intention to treat analysis. They also used this analysis of marginal structural models, where essentially they looked at data based on 30-day intervals of drug prescriptions to essentially make it as an as-treated analysis. And so what they found was that anticoagulation in this setting of patients with cirrhosis and AFib was actually associated with a mortality benefit with either warfarin or a DOAC compared to non-anticoagulating. And that there was a stroke reduction only in that second analysis of the marginal structural models. So where patients where they analyzed the data based on active prescriptions. It actually was a significant hazard ratio as well, though this is retrospective data. And the bleeding risk seemed to be the same, no matter what analysis you were using, and whether you're using warfarin compared to no anticoagulant or DOAC versus no anticoagulant. And there was a lower association of bleeding with DOACs compared to warfarin as well. So then are DOACs better than warfarin in patients with cirrhosis and AFib? And so here's this meta-analysis looking at DOACs compared to warfarin, and this one is on bleeding. So they divided up into regular dose DOACs and reduced dose DOACs, and it seems that any kind of dosing of DOACs was associated with less major bleeding compared to warfarin. And then in terms of stroke risk, there's a strong trend towards DOACs being or DOACs having less stroke or systemic embolism compared to warfarin. When they pooled all the data, it seemed to favor DOACs. And then what about in the population of patients with VTE rather than AFib? So this systematic review highlights the significant heterogeneity in treatment. So almost all of these studies also had a mix of atrial fibrillation in there, so they're not pure VTE populations. And they also weren't really able to combine the data. You can see all these various dosing regimens that they used. I just tabulated the total number of patients, and so most of the data would be with patients on rivaroxaban or Apixaban, with dabigatran being the fewest described. And so thrombotic outcomes seem to be similar when you look at all these numbers. The main outlier was this study, where they looked at DOAC arm and a low molecular weight or VKA or traditional arm essentially. And they found a much higher proportion of patients in this traditional arm having splenic vein thrombosis clot progression. This can somewhat be explained though, probably as the target INR in this study was 1.5 to 2. So it's not quite our standard. Then in terms of bleeding risk, they're somewhat all over the place. This study by Hum was the only one to have a significant difference in terms of bleeding. And one of the main differences between these two groups is that those on DOACs were on them for a mean of 319 days, versus those on this traditional arm were on it for 574 days, so almost twice as long. And then in terms of rivaroxaban, so there was a small RCT done in patients with provoked portal vein thrombus who had cirrhosis. And so they compared rivaroxaban 10 milligrams BID versus warfarin. And the 10 milligram BID dose, as per the authors, was used to avoid possible liver injury with full dose. And so what they found was that patients who were on rivaroxaban were more likely to have complete recanalization of their portal vein in a shorter time frame, or partial recanalization essentially. So all of the patients on rivaroxaban had at least some recanalization of their portal vein, whereas over half of those on warfarin did not. And those on rivaroxaban did not seem to have any complications, whereas those on warfarin had many different complications, including 40% of them having an upper GI bleed, and over a third of them dying by the end of the study. Another interesting finding was that they looked at baseline liver function scores and then reassessed them at the end of the study. So those on rivaroxaban didn't seem to have any progression of their Child-Pugh or MELD scores, but those on warfarin did seem to have some progression of their scores. And this wouldn't be explained all on its own by a higher INR essentially. So in this unique population, are there any predictors of major bleeding that can give us an idea of who may benefit more from DOAC compared to warfarin? Unfortunately, there does not seem to be, at least in one study of DOAC and warfarin users. In a pure DOAC cohort, they found that predictors of major bleeding in cirrhotic patients included those with a lower baseline hemoglobin, a higher Child-Pugh score, and those who had hepatocellular carcinoma or HCC. So I think from this side of things, it seems like anticoagulation is probably still beneficial in patients with cirrhosis, though of all these studies, there's very little data in those who have Child-Pugh-C. It's predominantly in patients who are Child-Pugh-A or E. Thrombotic prevention is probably pretty similar between DOACs or a traditional anticoagulant regimen. In this kind of the best study we have, but in this one study of provoked portal vein thrombus in cirrhotic patients, this rivaroxaban dose of 10 milligrams BID seemed to be better than warfarin. And there probably does not seem to be a higher risk of bleeding, at least anyone with DOACs compared to warfarin. Though again, much of this data is retrospective. It leaves itself vulnerable to bias, selection bias, and residual confounding. And in these studies, most of these patients at least were on their anticoagulant for around 6 months compared to the renal function studies where they were on it for around 3 to 4 months. So then in terms of my approach here, what do I do? Again, I think about mitigating bleeding risk factors. In this population, you have to contend with varices as well. So so hopefully getting them screened for varices if they haven't been recently, as well as treating them either with banding or primary prophylaxis with beta blockers. And I asked myself again, is anticoagulation truly needed? If not, then don't do it. If it's somewhat borderline, I think about, are there any significant unmitigated bleeding risk factors in this population? So again, frailty, these are extremely sick patients, a limited life expectancy. Does this really make sense to keep anticoagulation going longer at this point? Or do they have any other factors like chronic GI bleeding from portal hypertensive gastropathy or other or AVMs or things like that? Do they have any of these potentially higher bleeding risk factors, such as being child QC, having HCC, or being more anemic? If they do, then again, I discussed with the patient, I think we should stop your anticoagulant. And if they don't, as well, or they have a strong reason to be anticoagulated initially, and then I asked myself, well, is there an acute PVT because we have an RCT for this? And if there is, then this rivaroxaban dosing may be the best answer for them. If not, then I think, is this patient very severe in terms of their cirrhosis? If they're child A or B, then I think, I feel generally comfortable using really any of the anticoagulants if needed, with, obviously frequent reassessment and discussion with the patient. Or if they are child QC, then again, go back to, is this really needed overall? And talk with the patient, some informed decision making. I generally don't use warfarin just because the inodes are already elevated, and I just conceptually just have a hard time understanding how anticoagulated they truly are when they're on warfarin. So my 30-second summary for this is that these are very sick patients. There are high event rates of both thrombotic and bleeding outcomes. From the retrospective studies that we have, DOACs don't necessarily seem to be worse than warfarin in these populations. And then obviously just be wary of the selection bias, and that a lot of these patients were chosen to be on a DOAC, so there's probably some sort of patient factors that can't be captured in these studies that made the clinicians think you may be lower risk, or you might be a better candidate for a DOAC. Happy to answer any questions or share any feedback, criticism, anything that's good for me.
That's great, Dr. Tran. Thank you very much for that excellent presentation and that summary on kidney disease and liver disease and direct oral anticoagulants. We do have a couple of questions that have come through, and I'll start with kidney disease, given that's what you started with as well, and it's in particular related to patients that need anticoagulation for atrial fibrillation. In your review of the literature, or even your own practice, can you comment on deciding on which dose of anticoagulant to use, in particular if you're using Apixaban? Because as we know, the low dose of Apixaban is based on 3 particular patient factors, not just creatinine, of course. And so if you can comment on whether or not one would use 5 milligrams twice a day or 2.5 milligrams twice a day in patients that don't actually meet criteria for the low dose.
Yeah, that's a great question. The concern is always, even if you're using a lower dose, are you treating them effectively enough as it's wasn't studied in that way, or are you just exposing them to a higher risk of bleeding in that balance of thrombosis and bleeding? So generally, if patients don't clearly meet criteria for it, and if they're, say we're very lucky, they don't seem to have any other risk factors for major bleeding, then I usually feel a little bit more comfortable going with the full dose, the 5 milligram BID. And even, unless someone has a lot of active recurrent bleeding issues, I still generally start with the 5 milligram dose, and then if they have trouble with that, then I talk with them about whether we should, extrapolate and kind of guess and hope the 2.5 milligram doses will work for you, essentially.
Okay, great. Thank you. There's also a couple of questions coming through regarding patients with liver disease. In particular, the study that you presented looking at the rivaroxaban 10 milligrams twice daily for portal vein thrombosis. If you could maybe explain if there was a rationale for the study design of using the 10 BID as opposed to 20 once a day.
Yeah, so the authors talked about they used 10 BID in fear of causing worse liver disease. When the DOACs first came out, especially with one of the earlier correct thrombin inhibitors, Zymolgatrin, there was this worry about causing liver disease, and Zymolgatrin was actually taken off the market because of associations with hepatitis and liver dysfunction. Mm-hmm. So that could have been part of it, and so I think that probably led to as well why a lot of the landmark studies excluded patients with elevated ALTs. So that was the main reason why they did it, or at least why they said it. And we're looking at the literature of case reports of liver dysfunction or associated from DOACs. There doesn't seem to really be anything in that realm. And then is there actually a true difference between 10 BID and 20 milligrams daily? From a pharmacokinetic standpoint, there might be, but it seems like the 20 clearance of rivaroxaban might actually be potentially better if you use a BID dose versus 20 milligram dose is just a huge kind of bolus that then can keep the patient's anticoagulant status at the right level for the full 24 hours.
Okay, great. Another question that I have with respect to patients with liver disease, I'm sure you've experienced this as well, but depending on how advanced their disease is, they may have other complications such as thrombocytopenia. And if you can maybe talk about use of direct oral anticoagulants in that challenging situation as well. Is there a platelet threshold that you may defer to using a different anticoagulant, for example?
Yeah, that's a great question. I actually didn't think about including that in here, but I probably should have. So there's no real great data to guide us. I think the closest data we have would be in the cancer-associated thrombosis population, of where there are some suggestions of dose-reducing low-molecular heparin in particular. Versus DOACs, there's never really been any protocol or algorithm devised that helps you decide, if a platelet count drops to below 50, should I use half dose or should I use full dose? So generally, if someone is thrombocytopenic or kind of close to the, their platelets are in the, for sure below 50, you'd be a bit more concerned about anticoagulating them anyway. But if their platelets are kind of in the 80 range, I usually more so err on the side of using low molecular weight heparin instead in that population, just because then we can potentially, reduce doses based on weight or kind of completely extrapolating at that point. But there is a bit more leeway with low molecular weight heparin compared to the DOACs.
Yeah, no, that's great. I think I do something similar, and I think we've adapted a lot of that information, as you mentioned, from the cancer-associated thrombosis world, where we have a bit more flexibility with using a sliding scale, for example, depending on their platelet counts, and we can provide anticoagulation at various degrees of being therapeutic or intermediate dosing, for example, depending on that. So that's great. Thank you. We don't have any more questions at this point in time, so I am going to move on to our next speaker.